on the tape because we're actually running out of time. But have a think about the kind of how you can be creative and taking this resource back to your local areas and using them at a local level. As I say, both Daniel and I have used them, and we've been able to actually improve continence care just by getting people using the DVD and talking about continence and actually looking at different ways. And the key thing here is there's lots and lots of challenges. What we need to try and do is be creative and look for solutions and how we actually manage it. Okay, so number 5.
Continence can be promoted in a number of ways. It should not be stressful, embarrassing or ignored.
The staff have to appreciate exactly what continence is. We provide a very robust training schedule with regards to how we promote continence within the home, and what we try to do is we try to get the staff to put themselves in the position of the resident, because continence is something that can be so debilitating for somebody.
Sometimes there's a culture that becoming incontinent is just the accepted way of being, and we know that's not true. So we want to have staff, relatives, really thinking about what can we do to keep the person that we're supporting continent for as long as possible.
I think the key message that I would have to support this resource is think about the individual and not about their age or their abilities or their disabilities. To be creative, to look at the actual person and what they're going through, and even if they can't verbalise that they're embarrassed or they feel that their dignity has been compromised, we know that they do. It's not normal to be incontinent, and I think the key message is just that.
I'm hoping that the resource will lead to people actually questioning their own beliefs and their service culture and their organisational culture about bowel and bladder health, and ask the question why, if they have a high prevalence of incontinence, go back to the drawing board and ask the question why. Is it staff understanding, or is it the barriers I'm putting in place within the service that are stopping people from getting to the toilet? Or are people truly incontinent? Well, that's fine, but get them the right product that's best for them, that helps them lead a better quality of life.
So has anybody got any good ideas how we can get this DVD out there and using it in practice? It's really to think about how we use this DVD. It's an excellent resource, I'm sure you'll agree, and it's how we then actually use it at a local level. After today, take it back. Every single one of you have got a copy of the DVD. It's on your table for you to take away. A wee present for the Care Inspectorate. So the idea is that you actually take it back and try and find a way of using it to start the talk about continence and how we can get better at promoting it. And the key there really is about being creative, about how we actually get people to use the toilet whenever possible. And remember, as I say, going to the toilet is a very complex activity. It's not just as simple as going to the toilet. And if you've got any kind of other disabilities, you may be a bit immobile, you might have problems dealing with your clothing, your dexterity might not be so good. So actually it makes it even harder sometimes, so we get something called functional or passive incontinence. And obviously for us it's actually identifying if there's functional issues and then looking at how we actually try and engage with other services to try and support that person's independence where possible. So the top tips is decisions about continence care should be informed first and foremost by residents' preference for care and not being seen as an inevitable part of ageing. I think that's a key message we need to take away from today. Because you're an older person or a younger person, really shouldn't come into the equation. It's really about actually assessing that person from their continence point of view. Consider everything that can impact on an individual to remain continent. What can be done differently? And that's where the creativity comes in. It's really about being creative about how we actually deliver care as well, particularly where there's challenges for that to happen. Continence care practice should be monitored to ensure they align with evidence-based guidelines. But also remember, guidelines are guidelines, and often if you're going with the right intention and you're actually delivering good care, the guidelines will match up. Incontinence products play a role in the management of incontinence, but should not be the default model. Clearly, I think we've found that today with everything we've heard from this morning right through this afternoon. Some take-home message: a comprehensive assessment can significantly improve, in some cases cure, urinary dysfunction. Incontinence is a symptom, not a diagnosis, so if there's problems there, it's about actually understanding what's going on behind the scenes. A continence assessment is not a pad assessment. Treat, not containment. And remember to work with the person to identify individual goals, develop treatment plans and review the plans, including improvement against agreed outcomes and goals. And it's the person who's directing it, not us. And obviously there's 50 reasons not to change. There's often 50 shades of grey as well. And before we finish, we were going to do a wee game, but because we're actually running out of time, the suggestion would be that we pass on the wee game, let you go and get a coffee and come back into the hall for the finale. So thanks very much for coming today, and I hope you enjoyed it. Okay. Get back to you guys. You want your food?
1, 2, 1, 2.
All you do, press that arrow and that'll change.
The right one to the back.
In there, yeah, okay.
So the right-
Once your presentation's up here, all you do is you press that and it takes it forward.
Tab.
Okay? Thank you. And obviously the mics are there for you, so I'll hear you.
somebody did say to me, no. I think you said about keeping it informal, having a panel up on the stage. We're just, I need to track down who's still here. Who's still here, but I mean, Adrian's still here. As far as I'm aware, with the exception of Fiona, Dawn is still what I'll do is give me a shot. I'll just quickly go and drive certainly these afternoon ones. Yeah, so they're still going to appear. Adrian's going to be here. I just need to double. It's I wanted to open the full acronym. It's not Danish or something other. So seemingly it isn't because I had changed it to Scottish Continence Association. I went for it. Because that's not what it actually is. No. But seemingly whatever it is, it's in the list. No, as I say, I think it's a kind of one of these businesses. Davis. So certainly Adrian, what I'll do is I'll do a quick run round. So it's just basically the same setup as we had. If you want to there's any further questions at the end of each one, and then also this session. Yeah, and just have them at the end. We've only got 10 minutes, much better. We have one question. So it's a good one. You know, it's not always continence, it's not always stuff. Why? That's probably the one There is no.
I just start and everybody will sit down? Welcome back. Well, I hope you enjoyed the workshops and the lunch. Now we're into the final session of today's conference. I'd like to give a shout out to the people who are joining us from Highland, Aberdeen and surrounding areas, and the Western Isles. It'd be great to hear from you. If you want to join in the conversation, it's #ThinkContinence. There's been a lot of tweeting going on about this event, so we are spreading the word. I think as people now settle, we're just very keen to keep it to time so that everybody gets away when they expect to get away. And So I'd like to very much welcome, please, our next speaker, who's Gordon McKee, Senior Manager with SCA. You hear Gordon? Give him a round of applause and he might. Here he is.
Good afternoon. Firstly, on behalf of SCA Tenor, I would like to express my thanks to Jackie Dennis for the opportunity she's given us to come up here to present the audit findings. I would like to say that when Jackie first suggested coming up here to present findings, she didn't indicate it was going to be 300 people, and neither did she indicate it was going to be on YouTube. So thank you, Jackie, for that opportunity. I'd also like to thank all of the health boards who helped us during the audit process, their participation to allow us to work in partnership with the boards to gather all of the information. So I'd like to thank everybody involved in that. Just make sure I go the right way. That's it. First thing we've got here is a definition of a clinical audit. A clinical audit is a quality improvement process, seeks to improve patient care and outcomes through systematic review of care against explicit criteria and to implementation of change. And that's a nice definition from 2010. Looking at the audit objectives that we held and we discussed with the board prior to any audit, there's a number of key objectives. First, we looked to identify if patient prescription regimes were actually being adhered to and the protocols too. We looked to identify if the containment products used and supplied were being used correctly. We were looking to gain insight of the current clinical practice through a 24-hour snapshot of the COM. We're looking to identify any potential cost savings, and also looking to identify staff training and support needs. So looking then at the audit process, we actually audited 37 care or residential home facilities throughout NHS Scotland. This was all through 2015. There was 489 audit patients or residents audited. The largest of the care home facilities was 55 residents and the smallest was only 5. We covered right across NHS Scotland from the borders, Dumfries and Galway, all the way up to the islands into Orkney. So a full range of patient types, facilities, etc. were audited. And also we looked at large nursing home groups, smaller independent groups, and also independent care home single site facilities. So once again, a range of different patient types. Prior to the audit, the care home staff were provided with all of the documentation and all of the tools that they needed in order to fulfil the audit criteria. The care homes were provided in advance with a sheet, which was a PAD audit information sheet. I'll just quickly cover some of the content of that because it's important that you're aware of exactly what the care home staff were asked to do on behalf of this audit. So it said, firstly, that the aim of the PAD audit was, the purpose of the audit is to enhance the residents' continence care. So that was the reason for the audit. And a 24-hour product snapshot was required for the audit. Further that, the care home staff were required to measure the patient's hips and waist, record all of the fluid intakes, and record any fluid outputs. We provided them with a sheet, which we'll cover in a second or two, to put all of the detail in. Also to record when and if a pad was changed and what the pad was and what the pad was changed to. We also asked, and this is a key question, the reason for the pad change. And we provided some suggested reasons for the pads to be changed. We asked them all to save any used continence products, put them in a bag, and we even provided the bags for people to use as well. We would then go in the next morning and take the products out of the bags and weigh the bags. I'll clarify that. We didn't take the products out of the bags, we kept the products in the bags, but weighed the products in the bag. Any fecally soiled products were actually to be disposed of as standard clinical waste. So quite a detailed process to go through. Probably easier to understand it when you see the resident monitor form. Each of the patients that we audited had one of these completed on their behalf. There's a wee pointer on this. There we go. We looked at the home name, the resident name, the date that the audit was actually started, and also we looked at the hip and waist measurement of each resident. 24-hour snapshot covering from 8 o'clock in the morning until 7 o'clock the next morning, and we looked at things like fluid input, toileting regimes, if there was any, looked at reasons for pad change and also fixation products used, and also the description or name of any pad that was actually used. So what we looked to do was really get an opportunity, a real overview of that patient or that resident's continence management during that 24-hour period. We spoke earlier on about the importance of bladder diary and toileting regimes, so it allowed staff the opportunity to put any of these events down as well. So with that in mind, looking at the actual results of the audit, first thing to notice is staff compliance to the audit process was variable. From the initial 489 residents that we audited, the data from 106 residents couldn't be encoded. This was due to failure to comply with the audit process for various reasons. And these reasons included the fluid input and output details not recorded properly, the products weren't bagged or labelled accordingly, the products were incorrectly discarded, and there was incomplete documentation. So even though we had provided the homes with quite a detailed list and quite a stepped process, there was a significant number of the patients' data that we couldn't actually capture within this audit. So how that impacts on the findings and the results, we see straight away that because of the data capture being incomplete, we had 22% of the resident, 489 patients, that we weren't able to actually record into the audit. When we look at the product prescription regime's adherence, which is one of the key components, out of the 383 patients that we were able to get the details of, a total of 166, or 34%, were actually following the prescribed product regime and protocol. 44% were actually, more patients weren't, that number of 217, weren't actually following the correct product protocol or prescription protocol. So quite a concern straight away in the initial result. One of the things that we also found when we were looking at it, and as I say, we weighed the pads, was when we look at the actual number of pads used compared to its actual total amount of absorbency used, we see that there's an overwhelming majority of the products weren't used anywhere near the maximum working absorbency of the products. We weighed just over 1,000 products in total, and out of 1,000 products, there was 65% of those products were actually replaced before they had even reached up to 50% of their absorbency, and 85% of products were discarded before they had even reached 60%. So a huge amount of products changed long before they were anywhere near due to be changed. The key thing to remember, of course, is every one of these changes has an impact on that particular resident. It involves staff, it involves moving and handling, it involves an invasion of the patient's space and patient dignity. So each one of these allows for an opportunity, not so much for poor care, but more. So I'll start that again. Each one of these we found wasn't so much done through poor care, but was almost done because the staff didn't want somebody being in a wet pad or a used pad. So it wasn't from a negative reason that these products were being changed sooner. It was actually from an overly good, do you get what I mean? An overly good reason for that. So unfortunately that has a knock-on effect when we look at the other aspects of it, because what was happening was people were going through so many products that actually they ran out of their own products in many instances. And what was happening was they were having to then use other people's products. So when we were going in to audit it and understand what was happening, in many instances, people were actually on Mrs. Smith's products. Mrs. Jones would be on Mrs. Smith's products, Mrs. Smith would be on Mr. Brown's products, because they had went through so many different products. So we actually went to actually audit. We realised an enormous number, 93% of the patients, 356 patients, were actually on the wrong absorbency of product, an over-absorbent product. Now, there's been studies done, a number of studies done, about the dangers of using over-absorbent products. That can have a real significant impact, a negative impact on the tissue viability and the skin integrity of a patient. So to put people on over-absorbent products is actually more dangerous than putting them on under-absorbent products and to leave them in that situation. So out of that, we recommended that the 93% of patients that we audited at that point in time would receive a decrease in absorbency, with only a 7% increase in absorbency. Looking at the next aspect, which is product prescription change recommendations. Once again, it reflects the first two screens. Huge number, 85%, which is 326 patients, we would recommend that they change the prescription. And that's based on the data that was collected from the care home staff looking at the toilet regimes, the fluid input, the fluid output, and also the pads and the wearing. So it's all based on information that the care home staff gave to ourselves. The financial implications, well, if the recommendations for the changes in prescriptions are made and the prescription regimes are adhered to subsequently, just in these 37 care homes, they would achieve a first year's cost saving of over £21,500 at an average of £582 per care home. So an enormous amount of money potentially to be saved there. It works out roughly about £56 per resident in the first year. So a tremendous amount of money. The Professor McQueen mentioned earlier on, I've put down there there's over 1,000 care and residential homes within NHS Scotland. She came up with a figure of 1,249. It's a huge number of care home facilities, and if they are all overspending anywhere in the region of £582 on product, on incorrect product assessment, then it's a significant saving can come back to NHS Scotland. In summary, the audit has highlighted the following. Well, I think we know a significant number of these patient prescriptions may require review in this particular care environment. Incorrect product provision and low compliance in resident prescription regimes may also indicate that there's incorrect initial assessments being done. I think everybody's been given the stressed importance of correct assessments. We've also understood the lack of priority given by staff in this prescribing area. If you've got a staff member taking from one patient and giving it to another patient, would they do that with any other medication or any other prescribed product? Possibly not. So we may find that in this instance, this type of prescribed product might not be given the seriousness that it deserves. A lack of individualised continence care planning or process monitoring would be evident in that as well. And lack of staff knowledge regarding containment product functionality also became apparent, but people are replacing product after only 10-20% of actual product use can obviously show us that many people don't understand how the products actually work. We also have identified a potential overspend on containment products. So lastly, we're looking at feedback and recommendations. The home staff were provided feedback from the audit results in the first instance. I think it's important to allow people to go back and see exactly what the practice was that we identified and allow the homes to appreciate exactly how it impacted on them. The home staff were all offered audit training and support, and this included first and foremost about the importance of the promotion of continence. Each health board that we worked alongside has a programme of continence promotion, and we worked and we tailored our message along with the health board to make sure that the correct information was being passed back to promote continence in the first instance. We also looked to ensure that with the staff that the correct residents prescribed products regime was actually being adhered to. And when we looked at assessment, looking to ensure that the product is appropriate for the residents' needs at all times. We also reviewed fitting practices to include the correct use, using the correct fixation products. Use of wetness indicators, once again, goes back to understanding how products work, and this reduces the number of pad changes in total. We also looked at the importance of maintaining resident skin integrity and also improving toileting practices. We also look to provide supportive material to help staff ensure that the residents' products are used as prescribed, using locker cards and product allocation cards, etc. Throughout this year, we're looking to re-audit many of the homes that we've previously visited, and also in addition to that, we're going to identify new care homes as well and take that process forward. So, quite a lot of information we're trying to get into a very short space of time, and I appreciate we're kind of chasing time as well. So thank you very much for your time and for your attention, and I'll now look if there's any questions. I'm happy to answer them.
thank you. If you have any questions, or you'd prefer to save them for the question and answer panel, okay, well, thank you very much. Thank you. I'm sure somebody will bring you a question in a wee minute. Now, our final formal speakers today are talking about bowel and bladder medicines and whether they're being used correctly. Would you welcome, please, from the Care Inspectorate, David Marshall, and from the Elms Care Home, Kelly Island. Come on up.
Can I ask Gordon to bring us back the clicker, please?
I'll hand it up. Thank you. Right.
Thank you. And Jackie didn't warn us either. It was going to be 300 people in live streaming. She's sneaky that way. Beware. The presentation that Kelly and I have for you today was split into two parts. I'm going to talk briefly about the use, monitoring and evaluation of medicines in residential care services. And Kelly's going to talk about a targeted audit of laxative use in her care home and the improved outcomes it had for residents. Okay. Now we know that medicines are the most common form of healthcare intervention, unfortunately sometimes too common, which is why we have things like the government's polypharmacy guidelines or the tools like the Beers criteria or the stop-start criteria, all designed to help clinicians rationalise the medicines that they prescribe. These tools are very good, they will work, they do work. However, we live and work in an imperfect world. Reviews aren't always done as often as they need and in the manner that's needed. So if we're to get the best out of medicines for people who use care services, we need to give more focus and attention to the complementary and vital role that care services can play in ensuring the correct use, monitoring and evaluation of medicines. What do we mean by that? Well, it can be something as simple as ensuring that there's enough medicine to give when it's needed, ensuring a system that the medicine is there at the right time. Or it can be something like ensuring that the medicine is given at a time that suits the person who needs to take the medicine. And the second example down there, if the resident is generally asleep at 9 o'clock at night, it makes more sense to change the time of the administration. It can also be something like understanding how a medicine is meant to be used. In the example here, the laxative Movicol is prescribed in two very similar sounding but different ways. In the top slide, it's prescribed one sachet to be taken twice a day when required, meaning it might not be needed all the time, but when it is needed, it can be given twice a day for that resident. And the one at the bottom is prescribed twice a day and when required, an extra sachet when required, meaning for this person it should be taken twice a day on a regular basis with an extra dose over and above that if required. Unfortunately, in both cases, the medicine is only given once a day in the morning medication round. It can also mean, at a deeper level, probably the monitoring and evaluation of medicines and the condition that they're prescribed for. This is a principle that's enshrined in the National Care Standards and a variety of other best practice documents. So what does it mean? Well, it can be something like paying attention to key side effects of a medicine. So, for example, the antimuscarinic drugs are still a mainstay for urgent continence. They're very useful, however their use can be curtailed by some distressing side effects like dry mouth or increased confusion and forgetfulness. Care staff can have a key role in picking up on such issues. It can also mean having a system to evaluate and monitor the effectiveness of a medicine in meeting the identified care need. And this can be through the use of things like voiding diaries or bowel monitoring charts. The ultimate clinical decision about the continued need for a medicine will still lie with the prescriber, but care staff can have a key role in gathering that information, that evidence to feed back and help inform that decision. And Kelly will talk more about that in a second. I have a couple of examples where that maybe hasn't been done as best as it probably could have. This is the case of an 82-year-old lady. She was prescribed laxative Lexido, one sachet daily when required to treat constipation. Unfortunately, staff used it to promote bowel movement right up until the point that she suffered from loose bowels. That's the shaded areas there. They then repeated the process right up until the point the lady suffered from loose bowels, and so on. Now, unfortunately, nobody was actually monitoring this and asking the question, is this what we intended for this person? Is this meeting the care need? And so what we had was this repeated cycle of loose bowels. There was no monitoring. This might be a better example for you. This is the case of an 85-year-old man. He was prescribed 2 osmotic laxatives twice a day on a regular basis. He wasn't on any other medication that would very commonly cause constipation. In fact, if anything, the opposite. The shaded areas that you see there in yellow equate to loose bowels, days with loose bowels. And from the data that we know, he suffered from loose bowels for about half the time in the first month, in the second month, and the third month, with all the knock-on effects that has on skin hydration, skin integrity, hydration levels, and general well-being and dignity. So the care home were ordering the medicine that was prescribed and dispensed, but no one was actually asking, is this what we intended? Is this the meeting an identified care needs for this person? It's actually worse for that. He was also prescribed Senna twice a day. Senna on a regular basis. So for about half the time of that 3-month period, they suffer from loose bowels. So I think the key role for care staff in managing medicines is about ensuring that care staff have the right information gathered from a variety of potential sources to ensure the correct use, monitoring and evaluation of medicines. This means ensuring that staff know what a medicine is for and how to give it, how to use it. When the continued need for that medicine will be reviewed and how they can feed into that process, what monitoring of the medication and the conditions prescribed for needs to take place in order to help inform that decision about the continued need of the medicine. Now, this can be difficult to do if the culture's not right. I heard somebody talk about culture earlier on. I've got an example that maybe highlights that. Final example. This is a 76-year-old man who was prescribed 1 laxative, Senna. Now, we don't know if this was initially intended for short-term treatment of constipation caused by a stay in hospital a few months earlier. Possibly. More likely it was prescribed to counteract the effects of another drug he was on, which did cause constipation as a side effect. What we do know is that he was prescribed and received this medicine for 1, 3, 5 years of his life, 6, 7, 8 years of his life. Between 76 and 84 he was prescribed this medicine. We also know from the case review notes that in the middle of this period he was doubly incontinent, something that was managed through the use of pads and pants. So the culture here was not actually to question the continued need of the medicine, but it was simply to manage the incontinence. However, if the culture is right and questions are asked, I think that care homes can have such a positive and powerful role in managing medicines for residents, and laxatives included. And I'll pass over to Kelly to tell you more about that.
Ladies and gents, thanks for having me here today. I'm here to tell you the story at the Elms. I attended a training course much like the one you've just seen. David Marshall presented me with the mark sheets that you've just seen, and I went home with food for thought. So after the training, I kind of asked myself, so you don't just assume, just because someday a resident has come to us and they're on laxatives, you don't just assume they're always going to be on these laxatives. So, and it's up to me to start asking the GP the questions. Let's target a few residents to begin with. Find out the residents maybe that seem unhappy or seem distressed, and let's look at them individually and audit them. Now, I was already doing a monthly audit of my mark sheets before I attended David's training. But what was I achieving from that audit? I was going back and I was looking for maybe staff errors in the mark sheets, maybe occasions that they had forgot to sign. So I'm doing all of this on my audit, when actually I should be looking at the residents' well-being. So, altering my audit slightly, I started to look at, has a medication been administered as it's intended to be? If not, how often has it not been administered? Is the medicine meeting the residents' need? And can it be changed? So I've got a few real life situations at the Elms to share with you. And these are only a couple of examples. I mean, we've had effect on, so far, probably up to about 10 residents, just looking at our mark sheets. So I want you to meet Norman. As you can see in Norman's pictures here, he's got quite a worried look on his face. He found it really difficult to enjoy any means of activity, couldn't settle for his meals, and had very poor mobility going around the service. Norman was prescribed 2 forms of laxatives, so he was prescribed Senna at night and Movicol twice a day. At the end of the month audit, I found that the laxatives were often not being given, and I'm asking myself the question, why? So I've done a bit more digging. In January, I looked at Norman's charts and found that in January he had 7 occasions of unformed or loose bowels. He had 4 incidents. Now, incidents I'm talking about where he's actually struck a staff member or he's harmed another resident. 4 incidents of agitation and aggression. 7 episodes of challenging behaviour. Now, challenging behaviour in ABC charts we're thinking about where maybe he spat at a staff member, he's swearing at a staff member or another resident and causing agitation that way. And 2 significant falls where he's caused injury to himself. So that was in January. I then went and had a discussion with the GP. Now, initially the GP's asking me, why do you want to change his medication? He's prescribed this medication for a reason. And it was about me providing the evidence to the GP to say, this is why we need a change. So providing all the numbers from the previous slide in January, I was able to provide that as evidence for our GP. So initially they said, right, let's discontinue his Senna. So he was still on the Movicol twice a day and monitor the effects, and we'll have another discussion in February. So there was initial resistance there, but it was about getting them on side. In February, now bearing in mind changes to medication don't happen overnight, you're not going to see immediate changes. In February, we were able to look at his charts again and gather exactly the same evidence, but actually there was a reduction. So instead of 17 loose bowel movements that he had in January, he was now down to 8. We now had 4 incidents of agitation or aggression, 1 fall and no ABC charts. So he wasn't spitting or swearing at the staff anymore. He wasn't becoming aggressive towards other residents. So that was in February. I went back to the GP again and said, yeah, look, there is some positive changes, but it's still not where we want Norman to be. He's still not having a positive kind of outlook on the Elms, and he's not happy, as I would say. Let's look at the laxatives a bit closer. So the GP agreed to discontinue the laxatives altogether. So he was now not on the Senna and not on the Movicol. And the GP, I was given strict instructions, you have to monitor this, you have to keep an eye on this. So in March, I gathered up the same evidence again, and already we're down to 2 unformed bowel motions in March, or loose movements. He had 3 falls, but there was no kind of significant injury to himself. It was pretty much just losing balance. There was no incidents and no ABC charts whatsoever. In April, we had no episodes of loose bowels or unformed bowels. We had 1 fall, no incidents in ABC charts. So as you can see from the chart, it's just an overview of where we were at. So all the incidents are in purple, as you can see. All the ABC charts are in red, all the falls are in yellow, and the unformed bowels are in green. So we've done the review in January, and you can see a significant reduction in them all. So the outcomes for Norman, he had better bowel habits because of the reviews. He was much less distressed, so there was less incidents, less ABC charts, less physical aggression towards residents and other staff members, less episodes of challenging behaviour, a much happier Norman. And we were able to start building blocks with the GP and start developing a trusting relationship. And there's Norman after all the reviews. So that was at the end of a concert at the Elms. Norman had been up dancing, he sat down, he's absolutely exhausted, and he's singing to one of my staff members. So he's laughing, he's joking, and he's up dancing. Another example is Arthur at the Elms. Now, Arthur is clinically diagnosed with dementia, but he's still got some kind of self-awareness of what's going on around him. He had regular explosive loose bowels. He had a self-awareness of these loose bowels, so his mood was very low and he would not leave his room, wouldn't get involved. Now, previously Arthur was a businessman, travelled all around the world, was a social butterfly, and we couldn't get him to leave his room. So, auditing Arthur's medication, looked at it, he was on Movicol twice a day, and it was often not being administered. Why? Because he had these episodes of loose bowels. Back to the GP, let's provide evidence. So here's the evidence where we've got charts, we've got ABC charts of when the staff are trying to encourage him to come out of his bedroom. He's not happy. He's swearing at the staff, he's chasing staff, he's throwing things at them. He won't leave his room. Can we discontinue the laxatives? So providing all of that evidence, the GP agreed. The outcome for Arthur, he's now getting involved in a weekly tennis group at the Elms. Comes out of his room, looks forward to it every single Monday, and he's taking part in it. So he's physically active, and he's a much happier Arthur. So the learning points, I would say, if you could take anything away from what I've just said, is take the message that you don't just assume. Just because a resident or a service user is prescribed a laxative, and they always have been, don't just assume they need to stay on this laxative. Gather up the evidence. You've got all the evidence in your service. I mean, we're writing records constantly now, probably more than ever. So you've got the evidence there. Gather it up and present it to the GP. And be confident to ask the GP. Because initially, yeah, you might come against the kind of initial resistance of, well, why do you want to change it? Something that we've prescribed. But it's getting out of that culture and saying, well, actually, I'm here for the resident or the service user's well-being, and let's see if we can make a positive change to their life. That's me. Thank you.
Very much. Fantastic examples of the difference it can make. Now, I was wrong when I said that we'd had our final formal speakers, because there's one perspective we haven't yet heard directly, and arguably it's the most important perspective. Would you please give a massive round of applause for Izzy Duff, representing carers and service users. Thank you.
Well, good afternoon, ladies and gentlemen. I'm delighted to have been asked to come today and share a little about experience with you. Actually, delighted is probably a bit strong. I think, to be honest, I'm a bit daunted in terms of the fact that there are so many professionals here, a sea of professionals and academics. And what I hope to do today is just to give you a little bit of a flavour of what our life is like living with dementia and continence issues. And I've got off to a great start because I've not started the presentation. Yes, I have. Okay, so that's us. So this is our travels with dementia. My husband was diagnosed with Alzheimer's in 2001. He was 71, and for a number of years, his diagnosis didn't really have much of an impact on our lives. Other than the shock of the initial diagnosis, we continued life as normal. Bill had been retired for 10 years, and I was still working full-time as a primary school head teacher. I feel this is an important point to tell you that I'm not the same age as Bill. He's 85, he's 21 years older than I am. Over the years, things have obviously changed for us, but throughout the whole of the time since his diagnosis, we've done our very best to live well, or as well as we can, with dementia. Bill's dementia is now quite far advanced. We're lucky enough to have the support of two wonderful carers who I employ using the direct payment scheme. So Bill, of course, is at home with me. I'd like to give you a bit of a whistle-stop tour of the kind of things we do in our lives. All of the photos that I've used, you'll see in a moment, have been taken over the last 2 years, and most of them within the last year. As you look at them, I'd like you to remember that Bill is doubly incontinent. He can't manage his own continence needs, and he can very rarely communicate his continent needs through speech. So as I put together these slides of these activities, which are part of our lives, I decided I would use the key messages that are in the resource, the Promoting Continence for People Living with Dementia and Long-Term Conditions. And I wondered perhaps if you could keep these in mind as well as you look at the kind of things we do, and I'll come back to them once you have a flavour of the kind of things Bill does. Actually, one thing I took from this morning and will remember is it good enough for the bingo? Because I think that's basically what I'm talking about this afternoon. So what do we do? Well, once a week we go to the Dundee Alzheimer's Scotland Choir, Total Recall. Well, that's what it's called. We rehearse for 2 hours a week and we prepare for 2 major concerts a year, plus special events such as singing at the Caird Hall at the Rotary Club Conference in November. Our choir leaders ensured that breaks are built into the concerts and rehearsals so that everyone can enjoy the experience in comfort. So that side, that's us at the Caird Hall, and that's us at one of our early rehearsals. I'm in the red, Bill's in the blue, and we're in the middle of that in the Caird Hall there. Once a fortnight, Bill attends an art class. He's supported in his painting by students from Duncan of Jordanston Art School. And that's one of them with him there. And you can see why Bill enjoys his art classes so much. He's accompanied to these classes either by myself or one of his carers, so his personal needs are catered for. And the volunteers at the class, it's a Crossreach Heart for Art class, the volunteers help him with the painting. We've always loved travelling and going on holiday. Over the years, this of course has had to change in a variety of ways, but we still do our best to travel. We've had 2 holidays abroad in the last 2 years, one in Lanzarote and one in Spain. These have only been possible because I've taken one of Bill's carers with us. I discovered a very important fact when booking our holiday 2 years ago. Airlines will give extra baggage allowance for medical supplies. Continence products count as medical supplies. I obtained a covering letter from the Continence clinic and presented this at check-in after having made the arrangements on the phone directly with the airline, and presented them with this large bag of products. But it was fantastic because it meant I could still take all my luggage with me. As far as possible, we still go out to restaurants and cafes, have a cup of tea or something. You can see most of our slides involve a bottle of wine, I think. But we still do that kind of thing. I always do my homework before we go anywhere, and I tend to know what facilities are there before we go. We still visit with family and friends, maybe not as frequently as we used to, and these visits always have to be very, very well planned, and I have to think very carefully about whether we'll stay overnight with family when we visit now. That bottom one was taken in October. That's Bill with one of his carers. Bill's with him at his Keep Fit class this afternoon. Bill has a wheelchair, and we use it when we need to. He's always loved the theatre, as have I. And nowadays I always take him in the wheelchair, and I've found that staff in the theatres and cinemas can't do enough to help. Again, it takes a great deal of forward planning and thinking to allow this to happen. So these are only some of the things we do. So what about these key messages from the Continence resource? So, know me and what's important in my life and do what's best for me. This is about knowing the person's needs in relation to continence, maintaining personal hygiene, making sure the skin stays healthy, involving family and carers as well as listening to the person with dementia, providing the support needed and maintaining dignity. So what's this meant for us? Well, in a lot of ways it's been an uphill struggle, one which we really haven't conquered completely. The Continence Service has worked hard with us to advise and provide appropriate products, but we're still not there. I normally need to change Bill twice through the night, and sometimes all the bedding needs to be changed as well. So you can imagine the challenges that provides when planning a break away somewhere. Know me and how I communicate. Well, Bill very rarely communicates verbally. He appears to understand some of what's said to him, but it's very hard to know if he can actually process what's being said. Sometimes what he says is complete gobbledygook, but you can tell by his face that he's trying to communicate something, and it's up to myself and the carers to try and unpick what he's trying to say. It's really hit or miss if you get what he's trying to say. But at other times, he's actually quite articulate and will come out with quite a complex sentence. It's hard, though, to know if he understands what he's saying or if it's something that he's brought to the front of his memory from times gone by. One of his favourite words is precisely, said in a very sure and certain manner. Well, you can imagine the challenges that brings when trying to manage his continence needs. Do you reckon is another one of his phrases. Sometimes he'll flap his hands in an agitated way if he's about to have a bowel movement. But that's the best case scenario, and to be honest, he's stopped doing that more recently, so that's become quite difficult, trying to understand when he needs to have a bowel movement and know when we need to get him to the loo as quickly as we can. It's really, really important for us not to let him see how anxious we are about what's happening. Well, when I say we, I mean me. The two carers don't show that they're anxious at all, because they're not. It's me that gets wound up about things. Because he picks up very quickly on this, and he then gets into a panic, and usually some kind of disaster ensues. Well, I know that to my cost. We talked this morning at one of the workshops about pipe music in toilets. Well, I have to confess I hate it. The pipe music in the disabled access loos in the Overgate Centre in Dundee really got my back up. It was Christmas and it was belting out Christmas carols. I was getting stressed out, and Bill was picking up on this, refused to get out of his wheelchair, and ended up playing with the alarm cord. This resulted in the manager hammering on the door asking if everything was okay, and me shouting above the blasted music, "We're fine!" Anyway, what I need to stay continent and how you can help. This is actually Bill making a cake, not with me, I hasten to add, but with one of his carers. This is hard because I'm totally responsible for trying to help Bill be continent. I have the help of the carers and the advice of the Continence Service, of course, but it's me that has to manage this. Bill has a healthy diet, and all the advice given regarding fruit, vegetables, decaf drinks, etc., has been taken on board. He's also type 2 diabetic, and so that's important too. Bill isn't as mobile as he used to, so we don't do the kind of walking that we used to do. We use a wheelchair if we have to go any distance. He does go to things like walking, football and basic moves, that's where he is today, so he gets some exercise. His medication is regularly reviewed, but I did find the last presentation really interesting, and I might be going back to have a wee chat with the GP. But his medication is reviewed, and we do take advice, read timing of when it's given and so on and so forth. I've got the clothing aspect down to a fine art now. I know where to buy the best elasticated trousers, etc. But the one area we haven't got sorted out is the use of products to support Bill stay continent. And I suppose, listening to this morning, it's containing rather than staying continent. I'm really talking about. We've become fairly good at working out when Bill needs to go to the loo during the day and making sure that happens, but I'm well aware that we've not got that sorted out for overnight. Creating an environment that supports me to be independent and promotes continence. Well, as you'll have gathered by now, Bill isn't independent enough for most of the points listed here to be relevant to him. Well, they're relevant, but he can't be in charge of them. He is always accompanied to the toilet, either by myself or one of the carers, and we assist him in all aspects of toileting. We've been provided with some equipment from the OT department. We've got frames around the toilets, raised seats and so on. I've bought plastic urine bottles, which I keep in the upstairs and downstairs toilets, and I've got a Sangenic bin, and I've got the council to give me an extra black bin after a bit of a fight, because they won't do a special collection for hygiene waste. For our days out, I've got 2 bags. One big one, which has everything in it and can hang on the back of the wheelchair. It's got pads, wipes, gloves, bin liners, creams, spare socks, trousers, top, jersey, etc. And that goes with him to the day centre or when I'm taking him out for a whole day. I've got a small bag which can fit into my large handbags, and it contains the basics. 1 spare pad, bin liners, gloves, wipes, etc. And I take that if we're just going out for a short time. Both of these bags have portable urine bottles, which I sourced on the internet. Amazon's a wonderful thing, except for the one-click thing at 3 in the morning. At 8 o'clock I realise what I've spent. I've bought radar keys for myself and the 2 carers and for family members who might take Bill out. But imagine my joy to find that the disabled toilet outside the door of the Continence clinic was locked, but not with a radar key. Bedtime is another issue, one which hasn't really been solved. Bill has a hospital bed and he very rarely gets up through the night to go to the loo without my support. Normally I have to take Bill to the loo and change his pyjamas at least once through the night, and most nights it's twice. Sometimes it means the whole bed needs to be changed, sometimes just his pyjamas. So neither of us get a full night of sleep, ever. We've tried convene sheaths which were suggested, but Bill will not tolerate these. I found he pulled them off after a short spell. He was catheterised for a while when he had a spell of urinary retention, and he did his best to pull the catheter out. And he certainly managed to pull off the leg bag, and he certainly worked out how to undo the drain, open the drain. That's the biggest issue for us overnight, and it's one we certainly haven't addressed properly. Look for every opportunity to promote my continence. Be creative. That's, again, I've just copied the whole message onto the slide. I think in what I've said, I've covered most of the points there already. As I've said, the last 2 bullet points are ones which are still causing us most difficulty. Having said that, we won't be defeated. We had an appointment recently at our local Continence clinic. To be honest, through no fault of theirs, I still feel that we're no further forward. I do understand that when advanced dementia is part of the picture, finding solutions isn't easy. Having said that, I can't accept that we're at the end of the road. Having considered, again, if it was a fitting issue, I was asked to keep another 3-day input-output diary, but the feeling at the end of that process was that the product just wasn't suitable for Bill. However, this is part of our lives, and we'll sort it out somehow. The service is moving away from the current provider to another one, so I'm now trying out some of their products. And I have to report back on that. Perhaps there will be a plan B which will work better. Well, I hope I've given you some insight into our lives in terms of living with dementia and the challenges that brings in relation to continence. Nothing's ever easy, but the fact that we can still do so much together with the support of others makes it worth the hard work. I'm not ready to give up our breaks away. Holidays are too important to me. Or Bill's activities, because I think they're too important to him. As long as Bill's dementia will allow it, we'll continue. And I can't let the continence issues stand in our way. So even though I've been retired for 3 years, I find it really hard to take off my head teacher's hat. And we used to use this strategy when we were assessing the children's work. 2 good things and 1 that we hoped would be improved. 2 stars and a wish. We said, oh God, head teacher. However, for us, I think our continence service is working with us to try and find the best way forward. So that's definitely a star. Our daytimes are really well managed, quite well managed, so that's a star. And you won't be surprised to hear that my wish is that I'd like to find a way of having a dry night that would mean we would both get more sleep. So today, you've heard a lot about promoting continence, changing practice and making things better. I hope our stories helped you a little bit to put a human face on it. And I wondered if you could take a couple of minutes to think about your 2 stars and a wish. What will you take away from today? What 2 things do you think you are already doing really well to support people like us? And is there 1 thing that you think you can take away and perhaps improve on? What would be your 2 stars and a wish in relation to your own practice? Thank you.
Thank you so much. I think a wonderful way to end a brilliant conference. We haven't quite come to the end, though, because we've got now the question and answer session. I'd like to pick up Izzy's challenge, the 2 stars and a wish, but I'll give you more time to think about it. You said a couple of minutes. We'll give them that. But we have here some of the people that you've heard from today. We've got Dr. Wag, we have the final speakers you've heard, we have our workshop leads. So if you have any questions that you would like to put, and I include the people that are joining us from Highland, the Western Isles and around Aberdeen, then let's go for it. This is your chance to wrap today up, answer any questions you might have. We've had one question that's come through on social media so far. It comes from Amanda King, and she asked, why is continence not always seen as a priority with staff? Is it because it's easier to supply aids than perhaps to work out other interventions? I'll come back later, Izzy, to the 2 stars and a wish. But I wonder, Dr. Wag, can I ask you, why is continence not always seen as a priority with staff, maintenance of continence, rather than resorting to aids?
I suspect that there are always other more important things, particularly from a physician's perspective. And I suspect there is a natural lack of confidence in managing it in terms of actively treating. So the default is to stick a pad on it.
Anybody want to bring any perspectives in from this audience or from other speakers here to that? You know, do you think it's unfair to suggest, for instance, that staff don't regard continence, you know, as a priority? I've heard people talking today, from a frontline staff perspective, about the demands on staff time. That, you know, people working, say, in the care home sector have more and more asked of them, and yet there aren't more people to do it. Is that something that you would concur with? Is it a concern out there? Yeah? Can I bring you a microphone? Would you give me some insight to that? Thank you. Would you introduce yourself as well?
Of course. As I say, I'm Angela, and I'm a home support manager, and I support frontline workers who provide care at home. The workers that I support, you know, the job that they do, second to none. Getting in, assisting somebody out of bed, assisting somebody to wash, to dress, continence care, supporting them to and from the toilet, medication. So given all the support that they provide, you know, I'm saying every task, we're trying to get away from the task. It's a person-centred approach, it's knowing the person, it's meeting the need. But however, they're very needy people that we're supporting in the community and to support and care for at home. Recently we've provided training. Again, it's continence care training. It's looking at the person, looking at their continence needs, looking at their toileting needs. And what workers are feeding back to me is getting that information, getting that knowledge, and it can definitely inform their practice. So I would say we're getting better, however, we've got a long way to go, definitely.
To come back to Izzy Duff's wish,
Yep.
let's forget about the 2 stars right
Yep.
now. What would be your wish?
Yeah, my wish is that there's actually more information which can inform practice. And again, with the carers, giving the carers more support, if possible, giving them a bit more time. But again, supporting carers, they're frontline workers. It's great that individuals are living longer. Support them with information, with training, with guidance. Again, we're regulated with standards and codes of practice. Inform the workers of the codes of practice, of the standards, but the person-centred approach is very, very important. Get to know the person. Yep, thank you.
Very much. Fantastic contribution. Thank you very much. Would anyone else like to chip in on this one? You know, this is the demands on the people that are delivering the services on the front line to support people like Izzy and her husband and other folk inside care homes or in hospital settings. You know, it's a real issue. Do you need more people? If you had a wish out there working in those settings, is it about more staff? Is it about more time? I'm going to bring you a microphone.
It might be more about information and education, I think, as well. Well, this has been an eye-opener for us. I mean, I've been working in care for a long time and it's never been challenged. People are on pads, people are on Movicol, and it's never changed. And families as well, they're more or less just told, well, your loved one's incontinent now, you know, just pad them up and that's it. This is an eye-opener. For this to be rolled down more and into people at work and families, I think would help a lot.
Can I ask you to introduce yourself?
Oh, sorry. I'm Elaine Barr. I'm a senior at a day service for vulnerable adults, and we deal with that quite a lot as well. And it's getting action. You feel like you shouldn't say anything. I would hope so. More information for everybody.
Thank you very much. Anybody else got wishes, stars? Let's not ignore what's going well already. You know, what you think we should share best practice more? I'm interested in one of the issues that was brought up there about what I would call partnership working. You know, do people still operate in silos? You've got your GPs, you've got your care home specialists, care workers. You know, we're in this integrated environment, or so we hear. Do we need to go further? Does more need to happen with that? Yeah. I'm going to come back to you if you're not. Anybody else want to contribute to any of this? I won't make you. I'm going to bring you a microphone. Yeah, introduce yourself one more time.
My name's Ellen Foley and I work in a care home. But I think what is recognisable that it's now integrated care, sharing information, but I still feel that nursing homes are still out there and care homes are still on the peripheries, that people are still tend to leave us out of the information loop, and it's wonderful to see that it's now being all pulled together and the NHS and social care are working together, and hopefully that will improve the information and the knowledge and the support and the recognition that in care homes we have limited trained staff and we have limited resources. It's finite, it's not finite, it's really hard, exhausting work.
And thank you very much for it. There's a lot of people nodding here around you. Well done. Thank you. Anybody else want to chip in at this stage? Please feel free to just wave an arm and I'll try and come to you. Would you introduce yourself?
I'm Gwawd Ward, I'm a district nurse in Forth Valley, and the point I want to make is not just about continence, but it's about all the experience as a nurse that I have, but it seems to be the more expert you are, the further away from the patient you become, and that's throughout, not just continence, it's everywhere, and it is a worry, you know, and I know you can advise people, but it's not the same as giving the patient your expertise.
So what would be your wish?
That you value, or that people with experience are valued and encouraged to stay within the clinical setting and not just go higher.
Okay, thank you. A few more folk nodding around you as well. I'm going to come up to the back of the room here, and once again, if you wouldn't mind introducing us.
Chris Wallace, I manage the Community Continence Service in Dumfries. I'd just like to sound a note of caution about integration. I think we can't allow it to lead to us trying to provide more and more for less. Every time there's service redesign in health and social care, there seems to be less resource and more impact on staff. And we've heard several times today that a good continence assessment takes time.
Yeah. So your wish, give me your wish. How would you sort that?
Be mindful of the time that continence assessments take and allow staff that time and skills to provide it.
Fantastic, thank you very much. Anybody else while I'm up this end of the room, or I'm happy to run up it again, I could do with the exercise, so. Anybody? I mean, one of the things that I've learned today that has surprised me a little bit is that there's no Scottish guideline for urinary dysfunction. Have I got that wrong? I've got that right. It's in the process of being updated. Somebody by Twitter has suggested that that's an indicator of the priority that it's given nationally. Would that be too cynical a suggestion? Does anyone want to speak to any of that? You know, should we have a guideline for Scotland, or are we quite happy following what NICE does? Do we need something here? Anybody got any views on that? No. Okay. So can I come back then, please, to Izzy Duff's request? Your 2 stars and a wish. What do you think we do particularly well that we can build on? And has anyone else got any wishes that you haven't yet heard? It's about resources. I'm going to bring you this microphone. Thank you.
Hi, I'm Evelyn Newman. I'm the Nutrition and Dietetics Advisor for care homes in Highland. I think because Highland is an integrated service for health and social care for adults, there's a lot of things that we are doing very well up there in working together between social care and health, working with our residents and service users to provide a service and a care setting that suits their needs best. My big wish would be that food and hydration are used more than medicines. The work that was done at the Elms shows just how much laxative use really is not necessary. It's often the case that people are prescribed laxatives in community and it's perpetuated for no particular reason. And I think that would free up a huge amount of staff time and improve the quality of life of residents if we could improve their hydration and diet rather than rely on laxatives.
Thank you very much. Thank you. One of our speakers earlier on today sort of challenged us to think about what we would do differently as a result of what you've seen and heard today. Has anyone had any thoughts about that? I mean, have there been any kind of blinding flashes for you about, what you might go back and into your workplaces and do at all differently, or even know that you're doing it for the right reasons and, gives you greater resolve to carry on doing what you're doing? Has anyone got any thoughts about that? I think people have reached peak continence. Izzy, finally, can I ask you, I know you had your 2 stars and a wish there, but for other people that are perhaps earlier on in the journey that you've been on for so many years, what would you say to them about what they need to do to manage this for themselves and their loved ones? What should your wish for them be? For others, earlier on in the process, perhaps?
I think really just we were talking about listening, communicating and trying your best to get to know the people that are going to be working with you and for them to get to know you, so you build up a trust and can work together, and everybody's different, so everyone's individual needs will be different.
So the partnership?
The partnership, definitely, yeah. It involves the service use, depending on the stage of dementia, if it's dementia, the stage of dementia, the service user, the carer, the person, and the professionals working together. Yeah.
Thank you very much. I think that's a perfect point to draw this to a close. And I wonder whether I could ask, please, Jacqueline to come up and give us our closing comments. Where's Jackie? Dennis, here she is. Thank you. Jackie, who's been the driving force behind all this.
We're nearly there. 5 minutes and then I'll get off the stage and you can all go home. We've heard a lot today about how promoting continence can have a positive impact in someone's life and health and well-being. We've heard clearly that there's clear links between continence promotion and promoting the fundamentals of good care and the reduction of falls, the reduction of UTIs, the impact on the person's quality of life if periods are not monitored and reviewed to make sure they're being used for how they were intended. We've also heard that promoting continence improves skin integrity, reduction in moisture lesions. It leads to a healthier bowel and bladder if we can actually link in the diet and fluid of an individual. It also improves mobility if we actually see assisting someone to the toilet is not as a task but as a real opportunity, and we heard that this morning from Karen Reid. We've also heard how we care impacts on how we make people feel during this very intimate and private care activity. We need to recognise as healthcare professionals and individuals that our actions or inactions can impact on an individual to remain continent. Promoting continence is everybody's business, from the domestic in your units right up to the directors in your organisation. Ultimately, we need to move from a cultural position where we accept incontinence as the norm and move towards a culture where we openly challenge poor practice and deliver intentional continence care that always aims for cure and treatment, but where this is not possible, we always get the solution that's right for that individual and not over-reliant on the use of absorbent products. People living with dementia and long-term conditions and people in general with a dysfunctional bowel and bladder should be seen as people like us and not as someone who gets something done to them. We need to start seeing them as people like us. You've heard today quite a couple of questions, but again I'm going to reiterate, the big question leaving here today is, what one thing are you going to do differently as an individual, as part of your teams back at your work, and as part of your organisation, that will make a significant impact on the life of someone living with a dysfunctional bowel and bladder? We would really love to hear your good news stories when you get back to the ranch and back to your workplaces of things that you've done differently after today, and we at the Care Inspectorate are very keen in promoting that. So if you have any good news stories after today, please get in touch and we'll get in touch with you and we'll get you into the Care News and we'll publicise it, because the only way to foster good practice is to share good practice, and one thing will lead to another. Finally, I'd like to have a couple of thank yous. I'd like to take this opportunity to thank you for taking time out of your busy diaries, because I know it's been a long day and you've had quite a lot of information, and I bet your head's about to implode as you're driving home or going home today. I'd like to thank our fantastic speakers and that really brought this topic alive for me today. I mean, I'm still in a learning curve for continence, and every single time I hear people speak I learn something new, and hopefully you've heard that today as well. I'd like to thank Penny Taylor for emceeing fabulously and keeping us all to time, and especially to our healthcare teams, the Care Inspectorate's healthcare team and our comms team, who really helped to bring this event alive and to get you all here today. So it's really just left for me to wish you all a safe journey home, and when you receive your evaluation forms via the e-form system or via email, we really would love to hear how you felt the day has went, how we can improve it, or anything else that you would maybe like to see in the agenda for the future, and we'll be sending that through to you. So as I said, have a safe journey home, and thank you so very much for coming today. Thank you very much.
Thank you. You have to stay where you are for a minute, and I wonder whether Emma Dempsey is here as well. Is Emma around? Come on up, Emma Dempsey, because we have something to say. Thank you very much for putting this on the national agenda. Thank you. Brilliant. Safe home as well. Thank you.
I feel like an Oscar.
Your feedback will be solicited by email in a little while. Safe home, and thank you very much.